Newcastle disease virus, Newcastle disease virus, Newcastle disease virus.
Hi everyone, in this video we are gonna review some general aspects of Newcastle disease virus. So this infectious disease is an avian premix virus 1 that has different clinical presentations. The most common one is the acute respiratory disease, and in some other cases you can see neurologic or gastrointestinal signs. The clinical presentation is going to depend on the host susceptibility and also in the virulence group. So for this disease we have a classification which is that based on the virulence we can classify as lentogenic, mesogenic or velogenic virus. So the mesogenic and velogenic are going to be the most severe and are usually reportable. These are reportable. However, the lentogenic one is not reportable. So keep in mind that for your exams. The velogenic is divided in viscerotropic and neurotropic, and they can reach mortalities up to 100%. You can also see decrease in the egg production, which is important also in poultry. So the waterfalls are the least susceptible and chickens are the most susceptible, so that's an important thing to keep in mind as well. And unfortunately there's no treatment, so what is recommended is cooling of the animals. There are some lesions in microscopic examinations that some people say are pathognomonic. Well, those are hemorrhagic intestinal mucosa and multifocal necrosis. Just leave it like this is common and it's usually seen in the most severe ones. The gold standard for the diagnosis is virus isolation from oropharyngeal or cloacal swabs, and there's a zoonotic risk in people, which is manifested by conjunctivitis, but this is more limited to workers that are in close contact with the virus, either in a laboratory or in vaccination programs.
Newcastle disease virus. The most well-known avian paramyxovirus in the genus Avulavirus and the cause of a highly infectious pneumoencephalitis in fowl. It is also reported to cause conjunctivitis in humans. Transmission is by droplet inhalation or ingestion of contaminated water or food.
Hi, I am Dr. Ahmed Manjid Hamza Al-Shimmari, the head of Experimental Therapy Department at Iraqi Center for Cancer and Medical Genetic Research. Today presenting my work with my student Huda Ramiz and my colleague Maha Altai. The current work entitled Newcastle Disease Virus, Rituximab and doxorubicin combination as anti-hematological malignancies therapy. Hematological malignancies are a collection of heterogeneous conditions that originating from bone marrow cells and the lymphatic system. There are three groups: leukemia, lymphoma, and plasma cell neoplasms. Even with current targeting therapies as rituximab and other chemotherapeutic agents, there is need for developing new treatment strategies. Combination therapy seems the best option to target the tumor cells by different mechanisms. Viral therapy is a very promising treatment modality as it is selective and safe and cause cancer destruction. Newcastle disease virus, Iraqi strain, proved to be effective both in vitro and in vivo. The aim of this work is to investigate the novel anti-hematological malignancy therapy by using a Newcastle virus in combination with rituximab on CD20 positive tumor cells and with doxorubicin on CD20 negative tumor cells, whereas plasmacytoma cell line was CD20 positive as shown in this picture, which is tested by immunohistochemistry, and using lymphoma cell line, which is CD20 negative tumor cells. Isopolychroma analysis of combination for Newcastle disease virus and doxorubicin using different viral and drug concentrations which were applied alone or on combination for a 3 days exposure period. Figure A showing effect on the plasmacytoma cell line and figure B effect on non-Hodgkin lymphoma SR cell line, showing that there was additive and synergistic activity at low and moderate doses on both cell lines. Figure C showing a Newcastle virus with doxorubicin was antagonistic when tested on normal embryofibroblasts at most doses used. Isopolygram analysis and figure A showing synergism between a Newcastle virus and rituximab at low doses and antagonism effect on higher doses on CD20 positive plasmacytoma cell line. Figure B showing antagonism at most doses used on normal embryofibroblasts. The P53 quantification assay was used to determine the possible mechanism of action for synergism between the Newcastle virus and current therapeutic agents. In conclusion, the Newcastle disease virus is very promising anti-hematological agent when combined with other anti-tumor agents. It found to be synergistic with doxorubicin on low dose on plasmacytoma cells with no involvement of P53 pathways, but involved P53-1 combination used on non-Hodgkin lymphoma cells. In Newcastle disease virus, when combined with rituximab, showed enhanced cytotoxicity, which is P53 independent. These results indicate needs for further in vivo experiments.